So it's a great pleasure to invite our ARC chairperson, Dr. Chitra Ramamurthy ma'am, for a talk on iatrogenic ectasia.
Thank you. Thank you, Harsha. So it's been very enlightening hearing all of you, and much of iatrogenic ectasia in a way has already been discussed, but let me do a little more justice if there is a scope. If you look at this trajectory of how the laser vision correction evolved, you could see this was done in US and in Europe. It was seen that till 2014, there was an increase in laser vision corrections, 2007, and then after that there was a increase in adoption of PRK, which came back again, and phakic ICLs. But what was also noted during this time was that there was a small group of patients who were actually diagnosed to have ectasia, and these were in a mild to moderate range of refractive errors. So that really threw up a quandary among the proponents of refractive surgery. And then they decided that there were certain risk factors which have to be clearly defined. And these are the list which is there. I'm not going to go through all of it. All of us know which was absolutely mandatory to be considered to avoid a possible ectasia. And again, there were these ectasia risk scoring systems which are graded by 1, 2, 3, and 4. These were based on the topographic pattern, whether it was an asymmetric bow tie or skewing, or based on the residual stromal thickness in a younger age group, corneal thickness, and the higher the refractive error. So basically, as you grade, you would know that which are the cases which are more likely to go in for ectasia. So these were some markers. And then around 2014, there was a huge explosion of information that percentage tissue altered has to be looked into, which you're all aware is the flap thickness with ablation depth divided by corneal thickness. And it was seen that if it is 40% or more, the risk of iatrogenic ectasia is more, and rather 97% prevalence was there. But then there were so many patients earlier on wherein we didn't know about this PTA, and we have treated and they have not developed ectasia. So Santiago and Toll came up with his own study with number of others that PTA is not a holy grail, that it is just one of the important risk factors which has to be also kept in mind. Probably you could label it as one of the most biggest risk factor, along with all of which we had earlier alluded to. So one thing which is in our hands, which we have to really look into, is picking up those topographic abnormalities and picking up those form frustrate keratoconus, and of course looking at the Bellins and the overall D. And if you have access to Galilease, it helps you pick up form frustrate keratoconus even better than the pentacam. But there are now different tools which were discussed, which have come up for detection of early keratoconus. Like, we need to look at the higher order abrasions. And if the abrasions are significant, we need to look more into these eyes. We need to look at the biomechanics, epithelial thickness profile, and the Bowman's membrane. So in corneal biomechanics, even if you do not know too much of it, at least what you can understand is that definitely there's a lack of that elastic recoil, and the rebound phenomenon is not so much. So the deflection amplitude is what is being measured in these different biomechanical instruments. And what we have come to understand now, that Cirrus is, Corvus is definitely giving us some more information. Like, it tells you that if you look at the corneal biomechanical index and the bad display and the TBI, the TBI seems to be a little more informative. Now, this is a very frank case of a keratoconus. As we can all see, Bellins, overall D, everything is red. But if you look at this particular case, the CBI and the bad display is actually in green and yellow, whereas the TBI is in red. Now, this was a very obvious case, but there are certain cases where the topography is normal, but the TBI is little on the red. So it doesn't mean that just based on that, we exclude a case, but definitely we need to get very cautious. Like, if you're thinking of doing a flap-based procedure, it makes sense to do a PRK or probably a PRK extra. So we do see there's a significant improvement now with the TBI, and statistically it is better. The other thing is the epithelial thickness mapping, which was again well discussed in one of the earlier speakers, that the epithelium tends to get thinner over the cones. And if we are able to pick that up earlier, then you are one step ahead in diagnosing an early KC and avoiding these cases from being selected for a refractive procedure. Again, if you have access to the Bowman's layer mapping, if you're able to notice that disintegration at that level itself, even before the stromal changes have come in, that is again one more indicator. So having understood that we do have some tools and we need to make the best of them, now how do we manage iatrogenic ectasia? Now I'm going to run you through an example. Like this was a customized microkeratome procedure done in 2008. And that time we had access to the op scan and a high myo. Everything appeared normal at that time. And the patient came back after 7 years and with a frank ectasia, and definitely was very anxious. And the left eye was not very significant. So when you need to look at the visual rehabilitation for these patients, would you suggest contact lenses? Would you do topo-guided treatment or Intacs or ICL and dark? Then the whole series of questions come into our mind. But at that time, we knew more about CXL, and that was what was done for the patient. But then, having done that, we need to have an algorithm and approach about it. If it is a post-LASIK ectasia, would you advise contact lens to take care of this patient? And or if the visual axis was clear, would you wait for the progression to occur, then do a cross-linking, and then would then the next major thing which comes up is somehow in an iatrogenic ectasia, I would not wait. And I'm sure none of us would, because cross-linking is definitely a mainstay. So CXL at diagnosis seems to make sense here. But then there is a dilemma. CXL in iatrogenic ectasia seems to not to be very efficient because there's some inherent chain difference in the pathophysiology of these eyes. So probably the diffusion of riboflavin is a little not adequate. The other thing is what is important is that we are actually cross-linking the flap, which does not contribute to the biomechanics of the eye. And some of these corneas are actually thickener corneas when we've got to know that the patient has come back to us with iatrogenic ectasia. So we've decided that we would do CXL for these patients. But now with what knowledge we have, if it is a centered cone and there's fair amount of corneal thickness, would you do CXL alone or would you combine it with topo-guided PRK? And as was very beautifully discussed by the earlier speaker, that if it is a mild to moderate ectasia, if it is largely a centered cone, at least a thickness of 450 micron, we need to remember that we're going to remove only about 50-60 micron of tissue, and also the disadvantages, we are only ablating the flap largely, but we still would go ahead and look at correcting about some significant amount of refractive error and thus reshaping the cornea. So then we know CXL alone is stiffening, but then if we can combine it with topo-guided PRK, we are able to enhance the quality of vision. And again, this slide was shown beautifully. That's a combination of a central myopic treatment, flattening the central cone, and a little lifting up by doing a hyperopic ablation so that you have a larger, flatter cone, which can better withstand the biomechanical strain and the changes in the intraocular pressure or even the act of rubbing. And then when you cross-link it, it seems to make sense. Now, this is again a typical picture of how the patient had a pre-op cone. And then after doing the myopic and the hyperopic ablation, the visual acuity was improved at the end of 2 years, and the difference map shows it. Now, this is again a patient of ours who had a 624 vision and iatrogenic ectasia. And following cross-linking, it became a more symmetric surface, and his uncorrected visual acuity market improves to 6.9. So definitely it needs a thought that these are patients who had 6.6 vision and came to us for a correction of that 6.6 vision with the refractive error. We need to do everything which you can to give him back this 6.6 to a larger extent. Then the next question comes, would you do a simultaneous cross-linking with the surface ablation? Yes, it makes sense to do it because when you're doing the cross-linking and you're actually killing the keratocytes, and that itself is going to take care of some of the hairs post-PRK. The other question is, how does it make sense to do it at different times? Because after you have cross-link and then later I do a topo-guided PRK, I'm removing some of the cross-link tissue. Again, we do not have excimer lasers which have nomograms for laser treatment on a cross-link tissue. So it does not make sense. Rather, by doing a topo-guided PRK and then you cross-link, there seems to be even better perfusion of riboflavin because the absence of the basement membrane. And again, this was another thing which was well discussed, that doing a PTK and then doing the cross-linking makes sense, then a mechanical debridement. So then taking you further, this is again which is could be considered for iatrogenic ectasia too. I'm sure more information will open up that if we could do a customized cross-linking, that would be even more tailor-made, that it would give more energy to the focal cone and lesser energy to the surrounds, and then different customized laser patterns will evolve. So in an iatrogenic ectasia, as you would do in any keratoconus patient, you could do cross-linking with PRK, you could do PTK with cross-linking, you could do intracorneal ring segments with cross-linking, and phakic IOL with cross-linking. So just a brief about intracorneal ring segments. So we've understood that if it's an eccentric cone, and which is how it is largely in a post-LASIK ectasia, it definitely makes sense for us to consider intracorneal ring segments specifically in a post-LASIK ectasia. But of course, the same rules stand. We need to have a K value significant, at least a thickness of 450 micron in the 6 millimeter optic zone, and a poor visual quality. And then again, the same system of planning. You need to know the location of the cone, then you define how your segments are going to be, whether it's a centered cone or a decentered cone, and then you would decide whether it's going to be a thicker segment inferiorly or symmetric segments. All of this were discussed, so I'm actually moving forward. And more often than not, in a post-LASIK ectasia, you'll find that it is more decentered inferiorly, and then giving a single segment makes.
Sharing.